The scintigraphy, we used to study a lot about it, but most people have started moving away from it for the reasons we'll describe here. So it has been used to confirm biliary tract patency, but it is limited by its low specificity. The range is 68 to 72%. And a non-diagnostic result when the bile flow is limited as a result of other variable etiologies. So patients who have the interlobular bile duct paucity, idiopathic neonatal hepatitis, those on TPN may all have non-excreting scans. So that's why the specificity is very low. And obviously, sometimes we used to give phenobarbital for 5 days and wait, and all this delays the actual diagnosis. And that's why they're moving away from the HIDA scans, a lack of specificity and a possible delay from the need for simulation, so on. Yang et al. Had published a study looking at the different modalities to help differentiate obstructive and non-obstructive giant cell hepatitis. 69 infants were studied, and they underwent, all of them underwent these tests. The hepatobiliary scintigraphy had a sensitivity of 88%, but specificity was 45%. And it adds little to the routine evaluation, and it may help to rule out obstruction. So if there is a negative flow, it is highly sensitive, but your specificity is less, so you can't be sure it's biliary atresia. And they found that liver biopsy had the highest sensitivity in detecting biliary atresia and differentiating it from intrahepatic bile duct disorders like Alagille syndrome. It was quite high specificity and sensitivity. You have non-invasive modes of assessing like MRCP, and ERCP, of course, is not invasive, not specifically non-invasive, but it's less invasive. The problem with ERCP is the lack of suitable infant scope, and you need an expert, and it needs anesthesia. Magnetic resonance cholangiopancreography is non-invasive, and you can visualize the biliary system, including the first order branches of the intrahepatic bile duct. So if it is biliary atresia, you may be able to classify it based on the MRCP. It has a high sensitivity, but again, it's a low specificity. And we also have, if you're doing a liver biopsy, some centers may consider percutaneous transhepatic cholecystocholangiography, but most of them don't do it because the same information is often obtained by the liver biopsy result, and you don't get much additional findings.